Good afternoon, or barely good afternoon to those of you in Alaska. This is Bob Cantu. We're going to talk a little bit about management and chronic traumatic encephalopathy. The instructions are in the chat in terms of how you can receive your Category 1 credit. We have some disclosures. We don't have any conflicts. I think we can move along to the next slide. I think all of you recognize concussion as a type of traumatic brain injury that can be caused by a jolt to the head, as it is in most cases, but it also can simply be caused by the head being accelerated by snapping forward or snapping backward from a blow to the front or the back of the body. Normally, it leads to symptoms and or signs that clear up within a couple of weeks in about 70% of cases, and about 30% of the time, the signs and symptoms may last longer. When the signs and symptoms last longer, we call that post-concussion syndrome or persistent post-concussion symptoms, as most people refer to it today. The two terms are interchangeable. On the other hand, what is the focus of our talk today, chronic traumatic encephalopathy, is a neurodegenerative brain disease. It's caused by repetitive head trauma, primarily. Concussions count, but normally it's the thousands of repetitive hits to the head that don't produce immediate signs or symptoms that count even more. And typically the symptoms show up 10, 20, or 30 years after one stops taking repetitive head trauma. And then once they start, unfortunately, they are progressive in most cases, as the tau is spreading from one nerve cell to another in a prion-like way. And that's the major difference between CTE, which is delayed in its onset and progressive once it starts in most cases, and post-concussion syndrome, which is immediately after a concussion, the symptoms just lasting. But usually with post-concussion syndrome or persistent post-concussion symptoms, the symptoms are maximal close to the time of the last concussion and gradually get better over time, although in some cases it may take months or even years for the symptoms to totally go away. And in a very small percentage of cases, they may be permanent. Chronic traumatic encephalopathy, the clinical motor findings, the psychiatric findings, the cognitive findings were first described by Harrison Martland in a 1928 JAMA article called Punch Drunk. And it was first described in boxers. The neuropathology, both the gross pathology with the cavum septum pellucidum, with the enlargement of the ventricles, with the brain atrophy on gross studies, and on microscopic evaluation, the tau, hyperphosphorylated tau deposition in neurofibrillary tangles was first described by Corsellis in his article, again, looking at the brains of 15 boxers. Until 2005 and Benenamalu's publication in the journal Neurosurgery, CTE was recognized primarily in boxers. It wasn't recognized in other athletes from other sports. But that all changed in 2005 when Benenamalu and Stephen Dikowski and others described CTE, and Mike Webster, who's pictured there, a Hall of Fame NFL center. And then a very short period of time later, the next year, published another case in Andre Waters, who also had CTE. And with that, the race was on in terms of CTE being recognized in NFL players. and the media seized on it. Alan Swartz wrote a number of articles about it. Chris Nowinski was very prominent in bringing this to the consciousness of the American public. And pretty much the media rocket took off and the science started, but as science often does, it's much slower than is the media attention. Next slide simply points out that even the science has had a rather rocket pace for a new emerging disease, as we'll see on the next slide. Back prior to Anne McKee's first publication on CTE, in which she reviewed the 48 existing cases in the world's literature in which pathology was presented, and added 2 additional cases of boxers and 1 case of a football player, a professional football player. Starting with her publication in 2009, the publications with CTE started to rise significantly. And by essentially over the last 8 or 9 years, there have been more than 100 publications each year in the world's literature describing various aspects of primarily the neuropathologic diagnosis of CTE, but to a certain extent, its clinical findings as well. I think it's important to understand, as we'll get to in a minute, that CTE is a neuropathologic disease with basically a neuropathologic coding. On the other hand, the clinical disease of CTE has too much overlap with other neurodegenerative diseases, so there is no clinical ICD-10 code for chronic traumatic encephalopathy. The clinical symptoms, as we'll get to in a little bit, need to kind of be tangled away from other neurodegenerative diseases, primarily Alzheimer's disease. And presently, as we're talking to you today, that just hasn't been done with enough specificity to have a separate clinical disease category as CTE. Recently, there was a paper that was first authored by Chris Nowinski, but actually had a number of researchers and very highly respected people in the CTE arena that applied the same 9 Bradford Hill criteria that Sir Austin Bradford Hill applied to smoking and lung cancer in terms of smoking as a causative factor for lung cancer. In this case, it was applying repetitive head trauma as the causative factor for neuropathologically documented cases of chronic traumatic encephalopathy in the world's literature. And when this was done, a very strong case could be made for the fact that repetitive head trauma does cause chronic traumatic encephalopathy. Currently, it's thought of as a neurodegenerative disease caused at least in part by repetitive brain trauma. This brain trauma, much of it is of the sub level, I like that term, or better term might be non-concussive level. By that I mean it's blows to the head that register as hits to the head but don't cause symptoms or signs at the time that they're being incurred. And it's very distinct and very different from post-concussion syndrome, as I've indicated to you, because the symptoms of CTE normally come on many years after the trauma was incurred. And once they do, most of the time, it's progressive. It's diagnosed by specific tau protein, hyperphosphorylated pathologic tau protein deposition in nerve cells, in nerve axons. It can be in other tissue as well, but primarily in the neurons at depths of sulci around blood vessels in a kind of a patchy distribution. And I'll show you pictures of it in a second. This is simply showing that the neuropathology of CTE starts in the cerebral cortex and then goes from the cerebral cortex as it spreads to the medial temporal lobe in the amygdala and the hippocampus, as we see over here, of the medial temporal lobe, and also to deeper structures within the thalamus and even the cerebellum. These are whole brain sections on the top. This is a normal brain. That would be a sulcus. This would be a gyri, and that would be the sulcus between two gyri. And this is a whole brain section showing what would be stage 2 disease, multiple deposits of hyperphosphorylated tau at the depth of a sulcus, as you see here. And when we look at it in a microscopic view, we see it's around a blood vessel. And these are the typical neurofibrillary tangles. In other words, the nerve cell and their axon, that tail is actually the nerve fiber, the axon. This is the nerve cell itself. The nucleus is kind of the hole in the staining there. This is a mild case of CTE. This would be stage 2. This would be more than 3 lesions and up to 10 or 15 lesions, but just in the cortex. Here we see a higher grade of CTE. It's gone from the cortex up here, but it's also in the medial temporal lobe. And if we were to look at deeper structures within the brain, you'd probably see it in the thalamus. You'd probably see it in the locus coeruleus. You'd probably see it in the cerebellum as well. And when we look at the microscopic, you see ubiquitous deposition of tau, hyperphosphorylated tau, and then you see a blood vessel with tau accumulating around it. This is a quite high stage of CTE. This would be a very symptomatic person at this stage. This stage probably would be symptomatic with that many lesions, but if there were just 1 or 2 lesions, that individual might qualify for stage 1 CTE, but actually be asymptomatic. So the very most mild forms of CTE can exist without clinical symptoms or signs. The signs and symptoms, but here we're looking at the symptoms, and then over here some of the signs, basically involve cognitive issues, and the cognitive issues focus on memory, recent memory impairment, so-called episodic memory, as well as executive dysfunction, difficulties with insight, judgment, problem solving, multitasking types of issues. There also are behavioral dysregulation issues with impulsivity, verbal and physical explosive behavior, short fuse impulsivity, and paranoid delusions are also very common. In the mood area, it's primarily anxiety, depression, panic attacks, apathy, and hopelessness in many cases. There can be vestibular ocular issues with balance and blurred vision and trouble with eye tracking. And not infrequently, there can be motor findings. The motor findings be typically Parkinsonism type symptoms of bradykinesia, or there can be ataxia, other findings that go with the Parkinsonism, of course, of the resting tremor, the mask-like facies, showing no facial expression, and the issues with rigidity. It started in 2005 with Amalo recognizing CTE in football players, but just about every sport now with any amount of head trauma, especially repetitive head trauma, there have been cases of CTE found, and we have found quite a number in our hockey players and our soccer players. We've also found them in people that have been subjected to repetitive head trauma from other things like physical abuse, an abused wife, or head-banging behaviors because of autistic children with head-banging behaviors, or grand mal epileptics that have repetitive trauma from their grand mal seizures with head trauma as a result. Jesse Mez in 2017 presented 202 former football players and gave us a window into what the incidence of CTE was in the football players that we were seeing in the brain bank at Boston University. And when we looked at professional football players that were seen in the brain bank, virtually 99% of them had CTE, 110 out of 111 players. And that's pretty much held up from the years since 2017-18 as well. Now, this is not to say the prevalence of CTE in the National Football League is 99%. It's not. It's to say the brains we receive, which is a very biased sample, a very select sample, because these are almost invariably very symptomatic individuals. But if somebody has the clinical symptoms of CTE, they've had a high exposure to football like NFL players have, most of whom have played at the high school and college level, if not even the youth level before they got to the NFL, that they're going to have a very high likelihood for CTE. But it's also very meaningful to look at the college football players. Of those, 48 of 53, 91% had CTE. So even if you didn't play NFL ball, if you had a high exposure to years of playing and you played through the college years and you had symptoms of CTE when you died, you had a 91% chance, at least in those brains seen at BU, to have CTE. And even in high school, 3 of 14 brains, that's actually 21%, not 14, but 21% of those individuals had CTE as well. So just exposure through high school is not statistically, as you'll see in a minute, giving you increased risk for CTE, but we have seen people as young as high school with CTE. Most of these individuals have been people that have played other sports beside football, like rugby or ice hockey, and have played at the youth level right on up through high school. Jesse also was the lead author of another paper a couple of years later, 2020, that gave us a window into what was the exposure that was necessary to increase one's risk for CTE. And you'll see on the next slide that this paper looked at 266 deceased football players, 223 of whom had CTE, 43 did not. And there was a very strong dose-response relationship with CTE and the neuropathology of CTE. This has been consistent from the very beginning. When Martland first described the boxers in 1928 with punch drunk, that later that term turned into chronic traumatic encephalopathy. Bowman and Blake first used it in a textbook chapter, and Critchley would use it in peer-reviewed articles as well in the 50s. All of those authors found the same thing. That is, the people at greatest risk for CTE were those boxers that had been boxing the longest period of time, the greatest number of years, had taken the greatest number of hits, had done the most sparring in the gym, and had fought in a slugger-type mentality primarily, not trying to stick and run like Floyd Mayweather did for so many years. What Jesse and his group found is that the odds for developing CTE would double every 2.5, roughly, years. The severity of the disease would go from stage 1 to stage 2, or stage 2 to stage 3 every 5.3 years of exposure. And players who had 14 years of exposure to CTE, 14 years of exposure to football, had a 10 times greater likelihood of having CTE than individuals who had less than 4.5 years of exposure. So as you increased your exposure, you greatly increased your risk for developing neuropathologically documented CTE. Using Sir Bradford Hill's criteria, as I indicated to you previously, a very high correlation between repetitive head trauma and the neuropathology of CTE could be established. And this led the NIH to make some, I think, very dramatic changes. We'll see this new definition of CTE in the next slide. The National Institutes of Neurological Disease and Stroke acknowledge that CTE is caused by repetitive traumatic brain injury in October of 2021, just really a few weeks ago. And this came after a number of the world's top experts on CTE had sent a letter to the NIH making mention of Chris Nowinski's paper applying the Bradford Hill criteria for causation to repetitive impacts in CTE. The new statement that the National Institutes of Neurological Disease and Stroke put out is, quote, CTE is a delayed neurodegenerative disorder that was initially identified in postmortem brains, and research to date suggests it is caused in part by repeated traumatic brain injuries. And actually, this is the NINDS joining what the CDC had recognized for several years, and that they on their fact sheet list CTE being causally linked with repeated traumatic brain injuries defined as concussions and repeated hits to the head, called subconcussive impacts. Traumatic encephalopathy syndrome is applying the clinical criteria for this syndrome to living individuals to determine the probability that they might have CTE. It's a research tool. I don't think it's wrong for clinicians to use it, but I think it's important that it is something that is in evolution, and it's already been refined rather drastically once since it was first brought forward in 2014 in a more recent publication in 2021. And clearly there will be further ramifications and alterations as we go forward, but it's the best that we have right now. Using the criteria, first there has to be a substantial exposure to repetitive head impacts, and by definition that is the equivalent of 5 years of playing football with at least 1 year at the college level. Secondly, there have to be the presence of one or more core clinical features: cognitive impairment or neurobehavioral dysregulation, or both. And cognitive impairment is essential if you're going to get into a criteria of even possible CTE. The course over the last year of someone's life before their brain was examined or has to be progressively worse from their baseline. And that, of course, could be more than just the last year of their life that they've had a progressive course. The disease cannot be fully accounted for by another disorder, but I think that it's important to fully understand that the presence of another neurodegenerative disease, like Alzheimer's disease, does not exclude the presence of TES syndrome, nor does the presence of a substance abuse issue or a problem with post-traumatic stress disorder. So to meet the criteria of TES, one must meet those first 3 criteria, and then one determines the level of functional dependence And if the functional assessment is at the level of dementia, then one may well qualify for probable CTE. This is a pretty busy slide. The important thing to take away from it is the minimum exposure that qualifies you for CTE, TES syndrome is 5 years of organized football play. The amount of exposure in other collision sports like ice hockey and lacrosse is not known, nor is the amount of military exposure known. So we use the word a clinical judgment, the equivalent of 5 years of football. And if you think about what that really means, if the accelerometer data can be applied to these individuals, somebody takes maybe 800 hits on average a year at the high school level. You play 4 years, you have 3,200 hits. You play 5 years, maybe 4,000 hits. So we're talking roughly in that 4,000 plus range of number of these so-called subconcussive or non-concussive hits. Mixed in with that may be a number of concussions. And one day we'll probably find that concussions count more than the subconcussive blows. But right now we don't know whether that is accurate or not, and whether one concussion would equal 10 subconcussive blows, or whether a severe concussion might equal 100 subconcussive blows. That's for research in the future. This is a checklist that can be used for chronic traumatic encephalopathy. These first group of symptoms are talking about cognitive issues that go with it. The next go with behavioral dysregulation. There are motor issues. There are mood issues. And there can be vestibular ocular balance issues as well. And if you use this kind of a system, what you do is count up each time you see a patient, how many symptoms they have in each of these domains, the cognitive, the behavioral, the mood, the motor, so on. And also, what is the score? The tabulation of not just whether they have a symptom, but whether it's a 2 or a 3, whatever. And if you do that, you can get a very good idea of whether somebody is staying about the same, or whether somebody's getting worse or somebody's getting dramatically worse, what domains they're getting worse in, so on. And we use that, as you'll see in a minute, to help guide us in terms of the therapies for CTE. A couple of years ago, we wrote a paper with Andrew Budson on the management of chronic traumatic encephalopathy. And I'd like to spend just a couple of minutes going through how we manage patients with chronic traumatic encephalopathy. I think it's important to understand that the underlying neuropathology of it, the hyperphosphorylated tau, we don't have a therapy today to reverse it or stop it or slow it down. But we do have therapies that can reduce the symptoms of CTE and allow the individual to have a better daily quality of life. And we also have medications that can help as well, and that's what we're going to go through in the next few minutes. The paper was written basically directing people how they might manage the clinical symptoms of CTE, both with therapies and with pharmacology if the therapies aren't adequately working. Managing CTE can involve a number of neuropsychological tests to determine one's level of cognitive functioning. And these are some of the battery of tests that are very commonly used, neuropsychological tests to assess cognitive function in individuals. for an individual to be essentially significantly impaired, 1.5 standard deviations below premorbid functioning, or if we don't have previous testing, and we almost never do, then it's simply comparing them to normative values, which of course is a little dangerous, because if somebody is very brilliant, they can be significantly impaired for them and still test quite good, quite in the high average range. And that's, of course, the big advantage of if you have previous testing on individuals. Managing CTE, there are two things that will go with every patient, and that is exercise, which is beneficial for whether it's post-concussion syndrome or persistent post-concussion symptoms, or whether it's CTE symptoms, or whether it's dementia symptoms from whatever. Multiple studies have shown the benefits of aerobic and resistive exercise. So all these patients are put on an exercise program. All these patients are put on a diet that is away from an atherogenic diet, because vascular disease, hypertension, overweight, diabetes, so on, are all risk factors independently for dementia. So the diet tends to be of the Mediterranean type, lots of greens, fish, lots of fish, and staying away from very much in the way of red meats, and certainly foods that are high in cholesterol. If the individual's primary problems are in the cognitive area, then cognitive therapy is prescribed. And cognitive therapy involves, to a minor extent, memory type exercises, and to a major extent, learning a lot of ways that you can lay down memory better and retain things better. So it's almost like a checklist of learning tools. If their problem is primarily in the behavioral dysregulation area, then we have them work with our psychologists. We have them work with behavioral regulation specialists. Things that are useful for just about everybody is mindfulness and meditation. If they have vestibular ocular issues, or ocular issues primarily of looking at screens cause difficulties, tracking words on a page, tracking things on a screen are problematic, then occupational therapy can be very beneficial. Vestibular therapy is used for individuals with balance issues. Motor therapy is, physical therapy is used for people with the Parkinsonian symptoms, the bradykinesia, ataxia. All of these individuals undergo an endocrine assessment primarily focused on vitamin D and vitamin B12, which if low can contribute to dementia, and the workup of the pituitary gland. So you're looking at thyroid hormone, you're looking at adrenal corticotrophic hormone, you're looking at the sex hormones, and you're looking at growth hormone. Because the pituitary gland can be injured with repetitive head injury, as it can be from serious individual brain injuries, and when it is, and when something is deficient, often supplementation can have rather dramatic benefits for that individual, and it's never wanted to be missed. So everyone should be checked out with an endocrine assessment. So this kind of is just what we've been talking about. The physical therapies that we use involve vestibular therapy of balance is a big issue. If cervicogenic headache is an issue, it's cervical spine PT. Occupational therapy is used for the eye tracking difficulties, cognitive therapy for the cognitive dysfunctions. So it's really a team effort that these individuals may well use, because very frequently it's far more than just cognitive that's involved. It's often multiple domains of symptoms. If the individual therapies are not successful, then we'll use pharmacology as a backup or as an adjunct. We tend to use the therapies first and not go to the pharmacology first. The pharmacology that we use are the same ones that we use with post-concussion syndrome. If one is very early on and it's just mild cognitive impairment that somebody has, and that is the methylphenidate is the big workhorse. They go by a lot of different names: Ritalin, Adderall, Concerta, Strattera, Vyvanse. Sometimes we'll use amantadine if the methylphenidates aren't working. If it's reached frank dementia and or the methylphenidates aren't working, then we go to Aricept or Namenda, donepezil, memantine. These are the FDA-approved medications for dementia, most widely used in Alzheimer's disease. On the other hand, if explosivity, short fuse, agitation, explosive behavior is a big problem, then Lexapro for those over 12 can be very useful. Zoloft or sertraline is a workhorse in this category, as is Depakote. On the other hand, if it's pseudobulbar symptoms that someone is experiencing, so that what should elicit a sad response from somebody elicits inappropriate laughing, or vice versa, what should be something that makes somebody kind of merry and happy elicits a very sad response. So inappropriate laughing and crying, those types of outbursts, pseudobulbar outbursts, are often helped dramatically by Nuedexta, and is the medication of choice. On the other hand, if it's the very common depression, mood issue that is there, and this is probably the most common of the psychiatric symptoms that are experienced with CTE. Once again, those over 12, Lexapro can be useful, as can be sertraline, duloxetine, and fluoxetine as well. Those are all workhorse medications for the depressed. Realizing that Zoloft has weight gain very commonly with it, and the individual needs to be warned about that. If sleep, and especially falling asleep, is a big issue for these individuals, all of them get tried on melatonin because it's a naturally occurring substance, doesn't really have any side effects for almost anybody that is the least bit of a problem. So 6 to 10 milligrams in adults, pretty common dose, about an hour or so before they go to sleep. On the other hand, if the melatonin is not working or working inadequately, then it's a question of, if the problem is severe enough, then frank medication, sleeping medication, might judiciously be used. And trazodone, Ambien, risperidone, even Nuedexta is used in that situation, or can be used. It should be used very cautiously. I think most people for this indication would not be using it on a nightly basis, because the ability to get addicted to the medicine is very easy, and it becomes very hard to get off the medicine for some individuals as well. So if you're going to be prescribing sleep medications per se, probably best that they take them every other night, every third night, something which would reduce their chance for becoming addicted to it. If, on the other hand, we're dealing with physical symptoms in these individuals, as it will not be uncommon, and especially headache, then medications that can be very useful are amitriptyline at very low doses, way much lower than you'd ever use it for depression. And these doses have the advantage of also helping people get to sleep. So if you have somebody with trouble falling asleep and with headache, then amitriptyline is a very attractive medicine to try to kind of pick off both those symptoms with one medicine. On the other hand, Neurontin, which is really an anti-epileptic drug, is useful and used a lot. It's an offline use of it, but like most of these medicines that are used offline, it's very effective. Also, Lexapro, Zoloft, Inderal can be useful for physical symptoms in many people. Propranolol, a blood pressure medicine, is very effective for headaches for many people that are refractory to the other medications. And verapamil can be used as well, another medication that's primarily used for blood pressure. We're going to go through a couple scenarios that are useful in allowing us to kind of reflect about whether one is at significant risk or not so significant risk for CTE. So this first one, wife of a former professional football player complains primarily of sudden changes in her husband's executive function and memory. She is also concerned about his changes in impulsivity and explosive outbursts over issues that would not have bothered him before. He seems to be more withdrawn from their family and shows signs of depression. He played football for 5 years at the professional level, 4 years at the college level, 4 years at high school. So this individual played a lot of years of football. He's way above getting into being at risk because he played football for more than 5 years. He's not quite reached the 14.5 year tipping point for 10 times greater risk, but 11 years is where it really starts to get into the high risk category, and he certainly is in that. In addition to that, he shows clinical findings in all 3 of the major domains that go with CTE. He's got cognitive issues in the proper areas, executive dysfunction and memory. He's got behavioral issues with impulsivity and explosive outbursts, and he has mood or psychiatric issues with depression. So he has the clinical triad for CTE. He's got the exposure. If he had a progressive course, he would be someone that you'd be very concerned has CTE, and you would work him up for that, and you would also afford him treatment for his cognitive, his behavioral, and his mood issues as well. Next example, a man and his son were in a ATV collision and brought to the emergency department following some diagnostic tests and a physical exam. The physician determined that neither had a brain bleed, any lacerations required stitches, or any broken bones. However, the physician determined that the son had a concussion and advised the father of the return to learn protocol and an overview of what to expect during the recovery process. So here we're basically dealing with a man and his son, the son who was diagnosed with a concussion after an ATV collision. This individual from a single concussion would not be at risk for CTE. He would have to take many thousands of repetitive hits to the head to be at risk for CTE. So this single concussion would not raise any red flags about CTE. Now that concussion in and of itself, we don't know on day one in the emergency department how long the symptoms are going to last. We don't know how severe it is. It may be something that goes on to persistent post-concussion symptoms, but the thing is, it's not going to go on to CTE. So CTE would not be something that you'd put on your differential diagnosis for this individual at this time. This is a woman in her mid-50s who's been experiencing difficulties with executive function that have gotten progressively worse in the past 5 years. She's also beginning to demonstrate explosive behavior. She has no history of concussions on her medical record. but she discloses to you that she was in a physically abusive relationship for 10 years, beginning in her early 20s. She has no history of contact sports and has since been in safe relationships. Well, here you are going to be worried about CTE because this individual for 10 years was in an abusive relationship, possibly sustaining repetitive head injury. And she's got cognitive and she's got behavioral symptoms consistent with CTE. So cases 1 and 3, you'd have to be worried about CTE. That have to be in your differential diagnosis. Case number 2, you would not be worried and would not be in your differential. So what we know about CTE is that it's a neurodegenerative disease that's been recognized as being much more prevalent than previously thought. Clinicians, patients, and their families need to be able to recognize this disorder as its symptoms can be disabling. Although there are no published studies to guide our management of CTE other than what we just showed you, many non-pharmacologic and pharmacologic therapies have been used successfully in related disorders, and we recommend that the clinician consider these therapies when treating patients with suspected CTE. That's how you receive your credit, and this is the fun part for me. I hope that we will have a number of questions that we can respond to. Thank you very much for your time and attention.
Thank you, Dr. Cantu, for a great presentation. Can you hear me?
Hear you loud and clear, Michael.
Great, thank you. And for those in attendance, my name is Mike, and I'm a patient programs manager at the Concussion Foundation. Thank you for joining, and thank you for the questions we received in Q&A and direct chat. We'll address those, and if there's any we missed, we will try to address those via email. So do please submit your questions via chat with your email if you'd like. But just starting things off, Dr. Cantu, we had a question asked, are there any imaging or other biomarkers that we can use to assess CTE in patients in our clinics?
It's a great question, and I hope that within a very short period of time, maybe a few years, we will have specific biomarkers. Right now, there are a number of biomarkers that show great promise in group. In other words, a group of people that played football for a long time and had CTE, the biomarkers can be different from that group of people than a group of people that didn't have repetitive brain injuries or were subjected to repetitive head trauma. But one-to-one, just one individual, the biomarkers are not specific and sensitive enough at this time. It's kind of like the biomarkers for severe traumatic brain injury are sensitive and specific enough to let you know whether you've got a brain bleed and are being used in emergency departments to determine whether or not a CAT scan is done or not, but they're not sensitive and specific enough yet in concussion to be used for an individual patient to let you know whether somebody has a concussion or somebody's recovered from one. The biomarkers that show the greatest promise, though, include ligands for tau. In other words, they latch on to tau in the brain, and as you might expect, somebody that's got a lot of tau in the brain would be at risk for CTE. Unfortunately, tau is in the brain in a lot of neurodegenerative diseases, though, in addition to CTE. And when you can't microscopically get down to around blood vessels, patchy distributions primarily in neurons, can't see that in a macroscopic PET scan, you can understand why group accumulation studies can be positive, but for an individual, it's not quite there. It's also true, though, that brain MRIs hold some promise in allowing us to say whether something fits with CTE or not, because if you have atrophy in the frontal lobe area, in the medial temporal lobe area, if you have some enlargement of your ventricles, if you have a cavum septum pellucidum, especially a large one, this all goes with repetitive head trauma and CTE. And if you find that on an MRI, it doesn't diagnose CTE for you, but it certainly makes it more probable that you are dealing with CTE than some other process. Great question.
Cantu, another one here, and I'll go slow on this one to make sure I get it right. How should we evaluate possible CTE in the clinic and communicate what we have assessed with patients and their families, knowing that there is no clinical criteria for CTE or TES?
Well, I think what I do basically, TES is right now a research tool because it is being refined, it's being validated, and it hasn't been validated yet. But it is the best we have, in my opinion, right now. So I basically use it. I use it when I see patients in my clinic and when I see patients at risk for CTE. In terms of my thinking, I can't make the diagnosis based on it, but I can certainly sort out in my mind a differential diagnosis and levels of probability. I will say, though, that of all the criteria which have probably gone to the head of the class in terms of most likely predicting whether somebody has CTE or not, it's if somebody has cognitive issues, cognitive problems with executive dysfunction, with recent memory, laying down new memory, that is progressive. Whether there are behavioral dysregulation or mood issues or not, but if they're there as well, it makes it a little bit more probable. And that person has a very high exposure to repetitive head trauma by having played 11 or more years of football, then your ears really have to go up. This is probably CTE to proven otherwise, or at least CTE's in your differential very high, if not at the top of your list.
Thank you, Dr. Cantu. A couple more questions. This one related to the availability of care in Alaska. How would you prioritize assessments or telemedicine for a patient who is possible for CTE?
Yeah, telemedicine has limitations unquestionably, especially when you're trying to do a neurologic exam. You can do part of the cognitive exam orally, trying to remember words, trying to remember digits forwards and backwards, simple mathematical problems, serial sevens from 100, so on. You can't really have them as easily do visual spatial issues. And you certainly can't do eye tracking and a very good balance assessment. All that having been said, if it's a question of whether someone gets seen by telemedicine or doesn't get seen at all, I would always support being seen by telemedicine. If that is the only way somebody's going to be seen, it's much better that they're seen by telemedicine than not seen at all.
Thank you, Dr. Cantu. One more here. Is there a difference in symptom presentation with age?
Well, probably yes is the answer. There certainly is a paper, Bob Stern is the lead author on, a number of us are with him, that would suggest to you that there are perhaps two phenotypes of CTE. One is a clinical profile that starts in the younger individuals, people in their 30s who still may be playing their sport or recently retired from it. But basically the symptoms are there in their 30s and 40s and are predominantly behavioral dysregulation and mood symptoms, impulsivity, explosivity, short fuse, depression, anxiety, paranoia, apathy. Difficulties with cognition may be there, but if they are, they're very mild and they're not the prominent feature. The features are behavioral dysregulation and or mood issues. Those individuals, as they age, often pick up cognitive problems getting worse. but they don't usually go on to dementia as they age. On the other hand, the more typical CTE patient who presents in their 50s, 60s with primarily cognitive problems and or behavioral dysregulation and or mood issues. But cognitive is kind of the most significant and kind of driving the bus. And again, it's executive dysfunction and memory. These individuals tend, as they get older, to go on to dementia and die with dementia, and die largely from the inactivity that goes with dementia.
Thank you, Dr. Cantu. I'm going to leave one note in the chat here, and while I do that, I just wanted to ask if you had any closing thoughts or final things to communicate.
Well, I think the only thing that I would communicate is I hope some of this has been useful for you. You're definitely going to see people at risk for CTE. And as I indicated to you before, if you see somebody with cognitive issues, especially, and or behavioral dysregulation issues and mood issues, with or without motor findings, and that individual's been exposed to a very high degree of repetitive head trauma over a number of years, then CTE should be in your differential. And as you see that individual, hopefully you'll have some of the therapies that we've discussed available to you. And if not, or if they're ineffective, then there are medications that we also gave you on the slides as well.
Thank you so much, Dr. Cantu. We really appreciate your time.
You're very welcome.
And thank you everyone for joining. We will send the slide deck in a follow-up email and information about getting your credit. Thank you, everyone. That will conclude the CME.